And good morning, everyone. I can see that we've still got people being pulled through so that you can see us all. It feels even 12 months in, or however long it's been, that I'm still repeating myself on these Zoom sessions, but I'm sure you've all experienced it before, that it does take it's a bit of a lag as to when we go live and when people start coming through. If I can just ask Sir Michael to pop your video back on so that we can see you, although we can see a lovely photo of you, but we'd rather see you live. Perfect.
I thought the photo was better, but never mind.
No, we'd much rather have you live. Perfect. Thank you so much. Well, I will start us off, as I can still see the numbers are coming through, but you haven't come to hear my intro. So I will do the intro, and then by the time I've finished, everybody, I'm sure, will have joined us. So good morning, firstly. Thank you so much for joining us this morning for this event in partnership with MSD on a new deal for prevention. This follows up on a publication, a collection of essays, in fact, that we published with MSD back at the beginning of the year, looking at different aspects of what needs to go into a prevention strategy, and reflecting at that point, of course, on the government's summer 2019 ambitious strategy around prevention. It's always a delight to be able to say that I'm joined with a phenomenally expert panel for discussing the topic this morning. Really, my guests don't need introduction, but I will do so anyway. So first of all, we have UCL Professor Sir Michael Marmot, who everyone will be very familiar with from, of course, the brilliant Marmot review that was done a decade ago on health inequalities. And then, of course, we had the Decade On update just last year. We also have Professor Yvonne Doyle, who is Medical Director and Director for Prevention at Public Health England. I'm assuming possibly Office for Health Promotion going forward, but maybe we will touch on that. Hopefully everyone has seen that this is a brilliantly timed event to coincide, I would like to say coincide, with the government's announcement today of the Office for Health Promotion. And then finally, we are also joined brilliantly by David from MSD, who is the Director of Oncology and has also done a little bit in vaccines as well, but we'll talk broadly about the work that MSD is doing and how that fits into the broader picture of prevention. I won't say very much, but just very, very briefly to set the context. The government has come out saying that a healthy population is going to be their #1 priority going forward, which is absolutely brilliant to hear. And as I say, we have had the announcement of the Office for Health Promotion this morning, and I think it's fantastic that it's got a proactively positive name there in terms of what the government is wanting to achieve through it. Now, clearly, COVID-19 has both helped in some ways with focusing our minds on prevention and tackling health inequalities. The sobering fact that, of course, I'm sure people will be aware of, the sobering fact that if you are in one of our least advantaged, so one of our most disadvantaged communities, you are over twice as likely to have died from COVID than if you are in one of our most advantaged communities, showing just the impact that health inequalities can have. But equally, it has shone a light on the issue that we need to focus on, which is improving people's general health. Obviously, also, we have seen the fantastic work around diagnostics and testing and vaccines, which is a massive part of delivering a prevention agenda, not just for COVID, but of course for all sorts of diseases, both communicable and non-communicable. And as a final comment, and I hope we will get from our guests this morning, because we've got quite a good sort of selection of different, I guess, focuses within the prevention agenda, that prevention and healthy populations are everybody's business. We all have to take responsibility. That is from us as individuals and patients, the communities we live in, of course, the health professionals in both the public, private, and third sector who work day in and day out to try and improve the nation's health, our research institutions and pharma industry as well, who are obviously developing the kind of new diagnostic tools, looking at how we can use information and data better to understand our health populations, and of course developing new medicines as well to hopefully improve treatment. And of course then local and central government, as well as things like schools and employers, who all have a big part to play in delivering an effective prevention agenda. So I will shut up there. As I say, you have all come to hear our brilliant panelists. Can I thank you again for joining us, and obviously thank our panelists. We're going to have about 5 minutes-ish of opening remarks from each of them. I will then follow up with a few follow-up questions myself, and then I will open it up to Q&A. Again, forgive me, I'm repeating what you will all have heard a million times, but if you do have questions, and I very much hope you do for our panelists, there is a Q&A button. If you literally hover your mouse over the Zoom window that you've got open, where it says Q&A, if you just click on that and then you can pop your question into that. Please keep them relatively brief, because I do have to read them in real time to then be able to put the questions to our panelists. But if you use the Q&A function, please do not use the chat function. I will not be reading the chat, so please use that Q&A. Without further ado, as I say, delighted with the level of expertise that we have on the panel this morning to share their thoughts and insights on making sure that we do have a new deal for prevention coming out of the pandemic. I'm going to start with Professor Sir Michael Marmot, if I can ask you to give your opening remarks.
Thank you. I want to say 3 things. The first is, if you want a healthier society, you have to create a better society. Prevention is not just about having fewer fish and chips or running around the block. It's about creating better conditions through the life course. The second thing that I want to say is we're not doing well. The thrust of my report in February last year, the Marmot Review 10 years on, pointed to the fact that life expectancy had stopped improving. Second, inequalities in health had got bigger, both between levels of deprivation and regions. And in fact, the disadvantage of being in the Northeast and the Northwest gets progressively bigger the more deprived the area in which you live. And related to that, the third aspect of poor health was that for the poorest people, particularly women, in every area outside London, life expectancy was going down. That we're not doing well. Life expectancy stopped improving, inequality is increasing, and life expectancy for the poorest people outside London going down. And my analysis suggests that that's not just about the fact that people weren't listening to advice about smoking or drinking. We published Food Foundation figures. If you're in the bottom 10% of household income, to follow the healthy eating advice, you would have to spend 74% of income on food. People are not eating unhealthily because they didn't listen to the advice. They're not eating unhealthily because they're too lazy to cook properly. They're eating unhealthily because they're poor. And the third thing that I wanted to say is we know what to do. We know what to do. The evidence that I reviewed in my 2010 report suggested 6 domains of recommendations: give every child the best start in life, education and lifelong learning. Third, pay attention to employment and working conditions. Fourth, everybody should have at least the minimum income necessary for a healthy life. Fifth, healthy and sustainable places in which to live and work. And sixth, taking a social determinants approach to prevention, as I just illustrated with the cost of eating healthily. Now, all of those were made harder by the pandemic. As you said, Charlotte, in your introduction, the pandemic exposed and amplified the inequalities in society, which is why I called my December report Build Back Fairer. as we emerge from the pandemic. We should not want to go back to where we were before the pandemic, because that was undesirable. We were not doing well as a society. We want to build back fairer. And that means paying attention to those 6 domains that I've just elaborated that came from my 2010 report. And more generally, putting equity of health and well-being at the heart of all government policy. That's how we get a new deal for prevention.
Perfect. Thank you so much. And that is a brilliant opening set of remarks, and so many things that we could follow up on from that. But I will go straight to Professor Yvonne Doyle, if I can ask you for your opening remarks.
Thank you very much, Charlotte, and thank you everyone for joining us. I hope you'll enjoy this, but also I hope it makes you think what you can do as well in this huge endeavour to recover fairly. And just to remind people that there is already a 20-year gap in life expectancy between certain groups, and that is inversely related to unemployment and particularly to poverty and poor education. So what Michael says is playing out in the numbers. And if you look at how people live with quality, healthy life expectancy, there's an almost equal gap. And it's very interesting that that gap is there quite early, but it's really magnified in midlife. So in midlife, those who are healthy or very healthy are going to have much more healthy life expectancy in later years than those who are not. Why is that important right now, apart from everything else? Because we're going to have a 60% increase in people aged over 75 coming up in decades to come. So what happens to those people and how they both enjoy their lives but make contributions to society as a whole, where our balance will be a much older population, is an absolutely critical element of what we need to get put to rights together now. And that starts early, but it really, our efforts must go through the life cycle. And it is never too late, but it's really important to get that right, certainly from midlife. The second point is, what is the product? If you were, I'm sure there are people here from business, you'd say, okay, what's the product of investing in prevention? The product is health. And health is an economic asset. And we've just seen how economies can really suffer when you get this accordioned lack of health. We've been saying this about non-communicable disease, long-term illness for years, but you've really seen it fast forwarded in the last year. So how do we value health personally? Well, if we value our phones, our relationships, our gardens, our houses, we invest in them. And we consider what it is that we want to do to grow that. But we do not do that about health. So personally, we're not valuing our health, but collectively we aren't either. And governments, states have an important role to play in this. How do you measure health? And what is it that you are valuing in those measures that people actually say, I want that? And that's important to all of us, not just to me, but to all of us. And we haven't really done that. We've measured economies, but we haven't really put health into the mix as a national asset. And finally, I would say, don't itemize health. Don't sort of pick it off in bits. We'll do a bit of cardiology and we'll do a bit of, dementia. The mind in the body in the society is how we need to see this. And if we're really serious about prevention, first of all, fund it. It's never been properly funded. It is not better than cure because it doesn't get the same value as the investment in cure. Judge it fairly. So don't be duplicitous by asking preventive interventions to save money for the NHS. They're either valuable for society and for people's health, or they're not. If they're not, we should be measuring their effectiveness and getting rid of the ones that are not. But let's use the right paradigms for measuring prevention. And let's hold us all to account for doing it and not just talking about it. Thank you.
Brilliant. Thank you so much. Equally thought-provoking set of remarks. And it is striking that I think this view that it is not just the wealth of the nation, but the health of the nation that matters, is I think gaining traction in a really positive way. In fact, even the chief economist of the Bank of England talks about the importance of health to the economy. So I think when you get to that point, you know that the debate is shifting, which is great. And finally, last but very much not least, David Long, if I can come to you for your opening remarks.
Sure, thank you. Hopefully you can hear me well, and good afternoon, and it's a real privilege to be on the panel today with such distinguished guests, and I'll certainly do my best to provide some perspectives and be brief with that as well. So I think I'll talk mainly on sort of prevention, but also early diagnosis. I'll stretch the agenda slightly here, and I guess firstly, sort of responding to COVID-19, we saw happen through the last 14 or 15 months. Not all of it bad. There's been countless good examples of the system putting together to support getting patients in and getting patients through the system, whether that's from a diagnosis or treatment perspective, but also in terms of the prevention agenda. So whilst the system was hit incredibly hard, a lot has continued, and what we've seen is the collaborative work across the different sectors of the system, which really gives us a good foundation of what's possible moving forward, albeit probably in a more structured and better invested environment, let's say. I think we've seen serious impacts in terms of vaccination programs across the schools, but also across primary care as well, with VCR rates, vaccine coverage rates declining relative to a similar period in 2019. And obviously on the prevention agenda, that's not good. Equally, when we've looked at cancer and also preventative health checks in cancer and diagnosis, we've seen levels really decline substantially through the first lockdown, with referral rates from primary care into secondary care going down by up to 80% in some parts of the country. Whilst they've somewhat or largely recovered towards the back end of last year, we've clearly entered another period of a lockdown for 5 months or so, which has a continued impact on that. And I guess if we turn our gaze to lung cancer specifically, which is obviously a cancer which the inequality element is quite strongly seen throughout lung cancer, where you do see a demographic impact of lung cancer, and you can see some of the challenges there. It's definitely been an underserved community before, but also it's been very much exacerbated by COVID and all the implications that have happened there due to reduced screenings and reduced abilities for patients to be able to engage with the system, and often a common and overlap with some of the symptoms of COVID, certainly through the earlier part of the pandemic. So lung cancer has been particularly badly hit. We've seen diagnosis rates go down by about 20% across the UK. In some areas that's a bit higher, and subsequent then treatment rate go down by about 12 to 15%. So clearly something in terms of the long-term plan and having better outcomes for patients, which has been really challenging. And like I said, in areas with different socioeconomic environments, that impact is probably going to be much broader and much harder hit, and therefore the services and support around those patients will be challenged as well. Coming out of that though, and one thing we've done as an organisation, as a company, to try and support and help this is with a set of collaborations across the UK lung cancer community, Lung Cancer Coalition, Mesothelioma UK, and also Roy Castle, so to launch a public awareness campaign to really encourage patients to re-engage with the system, and if they have persistent symptoms of lung cancer, cough for 3 weeks or more, to not forget about it, don't deprioritize it, don't disinvest from it, invest in it and go and seek help and support from your GP first and foremost. So we've done some things to try and support. I think industry in itself is looking to find other ways to collaborate and support. And I think the last comment around investment is an interesting one. And I think it's also making sure the right levers are there from a government perspective. There's been a number of different reports that have come through in the last 6 to 12 months regarding what can be done. We've seen a very good report from Sir Mike Richards in terms of diagnostics within cancer, which clearly lays out a very clear roadmap to making the UK a world-class leader in diagnostics. So I think there are some clear recommendations, I think, to some of the earlier points. And I think it's probably then how we have the right investment up and down the system to ensure these can happen as well. But I think hand in hand goes with the collaboration across the different parts of the system as well. So with that, I'll wrap up and thank you very much for this great opportunity. And Charlie, I'll hand back to you.
Thank you so much. So I will start. I can already see lots of questions coming in, which is brilliant, and they are great questions and also nice and brief. So thank you, everyone. I will just start with a few follow-up questions, which kind of take us a bit more into this question around how we might tackle the health inequalities, which ultimately are probably our biggest challenge in terms of the prevention agenda. So, Michael, I wanted to come to you first. Now, I suppose two questions, and one actually linked to one of the questions that we've had put into the Q&A from the audience. But the government itself, in launching the Office for Health Promotion today, point out that, in fact, 80% of health outcomes are not related to healthcare. 80%. I mean, that's huge. But we've known this for quite a long time. You very eloquently described the almost non-lifestyle factors, actually, the social determinants, as you put it. If actually 80% isn't about what we do with healthcare, how do we move away from seeing this still as an NHS, broadly an NHS problem? And to pick up the question we've had, are there good examples, either in this country or abroad, that you've seen that show what best practice might look like in terms of moving away from a very health-focused lens on prevention?
So I would say, just a language question, distinguish between health and healthcare. When you say a health-focused lens, what you're implying, and if you read the IMF or the World Bank or other organizations, when they talk about investing in health, they don't mean that. They mean investing in healthcare. Investing in child education is investing in health, but they don't mean that. They mean what a country spend on health care. And that's very important, because to come back to your question, if we look at the last decade, let me start with the bad news and then the good news. So the bad news of the last decade is child poverty went up as a direct result of government policy. It was government policy to increase child poverty. That's very bad for health. That's not a good thing to do. And what do I mean by government policy? Well, if you looked at changes the Chancellor made to the tax and benefit system by deciles of household income for families with children, as a result of the changes the Chancellor made, the income of the poorest 10% would go down by 15%. And the next 10% would go down by about 10 or 11%. And then the richer you were, the less the reduction. That was government policy. So if you have a set of policies that are designed to make inequalities worse, are designed to make poverty worse, if you look at funding to local government, the poorer the area, the bigger the reduction in spending by local government per person. In the least deprived 20%, spending in local government went down over the decade by 16%. And in the most deprived quintile, it went down by 32%. Clearly regressive. That's designed. It may not be explicitly designed, but that's designed to make health inequalities worse. If you wanted a set of policies to make health inequalities worse, that's what you would do. The more deprived the area, the bigger the cuts. So that's the bad news. And that's what it means to put health and health inequalities central. You don't do that. You don't pursue policies that make child poverty worse. You don't pursue regressive policies of funding to local government. You don't do that. That's what it means. So if you're serious about leveling up, you put disproportionate investment into poorer areas along the gradient. The more deprived the area, the greater the spend. We did the opposite in the last decade. So that's the bad news. The good news is that local government really, in many areas, tried to embrace this agenda, because you asked, are there good examples? Coventry declared itself a Marmot city. We're working with Greater Manchester, and we're about to produce the executive summary of our report for Greater Manchester. They've taken this really seriously. Cheshire and Merseyside, Gateshead, Newham approached me. They want to work with us. North of Tyne has approached me. All around the country, there's local government who say, we're convinced We starting with early childhood and going through the life course to older age, the kind of things that Yvonne referred to. We're convinced this is vital, the conditions in which people are born, grow, live, work, and age, the social determinants of health. So I'm really encouraged by what city and local governments have been doing.
Perfect, thank you. And so I guess leading on, Yvonne, from that positive note that actually there's a great appetite out there at local government for driving this agenda. You mentioned both how we measure success, which strikes me as one of the most important things in government, because what we tend to measure gets done. And therefore, if we're not good at measuring it, then that's trickier to force people to kind of really engage in it. Are there things we could be thinking about in terms of how we better measure impact in terms of the prevention agenda? But also following on from Sir Michael, are there examples that you also would point to of saying, actually, here is some best practice where we have seen the right combination of actors come together to drive better outcomes for those populations?
Yeah, so I think I could answer the both questions in one, really. I think, this country is renowned for the quality of its measurements. And I've just been doing a series of international interviews around the pandemic and how countries have fared and why they fared and what they would change. Practically everybody says that this country is renowned for its collection of data and the way it uses data. And actually, I suppose for Michael, the good news is that they all recognize that this country actually does measure inequalities. A lot of countries don't, including, modern democracies that are comparable, we're comparing like with like. So that is one piece of good news. The question is what you do with the data. I would say we are replete with data and with indicators, and we could construct new ones like health indices. We could just spend our time doing that and not do what I like best, which is, what do you do then? What do you implement? And how do you work with the organized efforts of society? And, in London, we did a lot of that. It wasn't just with the political leaders of London. We worked with business, we worked with the City of London, we worked with religious leaders, and that is still very active in London at the moment. And indeed, as Michael has expressed, in other parts of the country, we're using our partnerships to try and protect people. And eventually, when we get out of this, we'll use our partnerships to try and promote and, lift people up and, as they call, level up. But you must do it at every level, from national right through. And I do think, Charlotte, we need to hold ourselves to account here. I'm part of this. I want to be held to account for what is different, and to not feel good and relaxed about any of this until we can demonstrate improvement, no matter how long that takes. And that's where we, I think, fall down. We don't do that. We produce magnificent stuff that everyone celebrates and nothing happens. So it's the how does it happen bit. There are good examples, there are plenty. You need to stick at it.
Perfect, thank you. And David, coming to you, you mentioned lung cancer and cancer more broadly. And so I'm thinking of kind of in terms of a specific example of one of the areas where we can see significant inequalities. Yvonne mentioned data. That has been, people have talked a lot about how we could use data more effectively to do things like early screening and diagnostics, identifying groups that have perhaps higher risks, and there will be particular groups in lung cancer, for example, smokers or older people. And is there an opportunity here for us to, taking the example of cancer, to be smarter about the way we identify people early, so that actually we can ensure longer, healthier lives for those populations that sometimes get left behind? And equally, are there mechanisms that we could be using in order to do that? So I'm thinking, again, Yvonne talked about the collaborations we've seen during the pandemic, and we have seen, I think, quite a step change in different partnerships. We've also had much more talk about things like, diagnostic hubs and mobile units to be able to go into some of those communities that perhaps are harder or have historically been harder to reach. Is there an opportunity here, both in terms of the data and the willingness to be a bit more creative to tackle health inequalities that you see in terms of cancer?
I think, in a word, yes. Absolutely, there's opportunity there, and I think one of the challenges with the data, I think to Yvonne's point, is that there is so much. There's so much, and we can look at so many different metrics, and so much is measured. And I think some of the challenges, what are the consistent things we're looking at? What are the metrics that we judge ourselves by? What are the metrics we set for ourselves, and are they the right ones? So I think assuming that all of that can be fixed, is then how do we integrate the systems to do it? And I'm absolutely not an IT expert, so I'm not going to profess to know how to do this, but we do need to strive to have systems connect better, so that across different regional areas or health bodies or health boards, that the data can talk to each other, and there can be a consistent approach across the pathway, across the system, all the way from prevention to hopefully treatment and management of the patient post-treatment as well, so that things do line up. And I think one of the things that does, I wouldn't say concern me, but I think we have to be really cognizant of when it does come to data and digital and these types of approaches, is how do we make sure we're reaching the right patients as well? When we do look obviously at what happened through the pandemic, and digital consultations, let's take for an example, is a completely different way of managing and interaction with a patient. In some ways fantastic, it enabled the system to continue, and actually probably got access and the discussion more broadly around the support network around the patient. If you can imagine a consultation for cancer, the ability to be able to do that with a patient's family or carers there is really good. However, for those patients, potential patients without access to digital, without access to some of the tools that are available to a lot of other people, there's almost a bit of an inequality that comes up there as well. So I definitely think digital and data will play a huge role. I do think we need to figure out what we want to solve, and then get the data help us to do that. But also I think we shouldn't expect it to do everything for us as well, because there are still quite some gaps in terms of making sure we can reach those hard to reach patients. And it will probably be a more analog approach or a more traditional approach sometimes you might have to take to get out there. I guess on the point of screenings, absolutely, I think there's a number of different approaches to try and understand and go and find patients that will be at risk. There'll be probably a number of different projects trying to explore that as well, about how you do reach into communities, to activate the communities, to really get the patients to come forward as well.
Which is definitely one of the things that we've seen with the vaccine rollout, that hopefully we can sort of piggyback off the back of to try and apply to other areas of healthcare, I will say, rather than health more broadly, as Sir Michael rightly put. I'm going to now start going through, because we have got a lot of questions coming in, so I'm going to try and work through. There is some overlap, so forgive me if I don't get to your precise question, but hopefully we'll get through as many as possible. So I'm going to start with one for Sir Michael, which in fact opens saying that you're the kind of David Attenborough of health and equality. So so rather a nice way to put it. This question asks, and I suppose perhaps I would put it then afterwards to the rest of the panel. We have touched on this, but if there's other areas, does COVID give us an opportunity to have a different Marmot report in 2030? And if it does, what specific things, perhaps just a couple of things, because I'm sure there are many, but what specific things would you want to see happen now in order to deliver a different report in the next decade's time?
So I'm smiling about the David Attenborough. Presumably lockdown's done for his travel what it's done for my travel. I was just reflecting, my last overseas trip was to Amman in Jordan for our Eastern Mediterranean review at the very end of February 2020. And that was it. Everything got cancelled after that. It's hard doing global health during a global pandemic. It's all done from my desk in North London. So we've got to come back then to the question. We have a wonderful opportunity. The question is, are we going to squander it? The pandemic has exposed many things if we're only open to the lessons that it's been teaching us. We started by saying that it exposed and amplified the underlying inequalities in society. That was the first. Second, it told us quite how important government is. The nonsense about the discovery of the vaccine shows the importance of greed is complete and utter nonsense. The development of the vaccine shows how you need all parts of society working together, how you need basic science funded by the science base. You need a government that's willing to take risks and invest. If the government hadn't taken the risks, you've heard me be very critical of government. Let me be praiseworthy of government. The government took the risk to invest in the vaccines, not knowing if they would work. Wow. Big plus for the government, great plaudits for the government. And then we needed the private sector to work. And so the idea that this taught us something about greed is complete and utter nonsense. It taught us about how important the various parts of society are, the science base, public investment, the importance of government, the importance of the private sector, and working together. So that's, thirdly, it should have taught us who keeps society functioning. I don't know who you were clapping for at 8 p.m. on a Thursday evening, alongside clapping for the healthcare workers. What about the workers in social care? What about the delivery drivers? What about the refuse collectors, the dustmen and recycling people who kept it all going? What about the people working in the supermarkets who put themselves at risk in keeping society going? I doubt that many of us were clapping for bankers and hedge fund managers on Thursday evenings, but we recognized who keeps society going. Are we willing to learn the lesson of how miserably we treat these people in terms of paying conditions at work, apart from how they live in society more generally? So, and we should have learned about the importance of science. I agree with Yvonne completely about the brilliance of our data. ONS, our Office for National Statistics, forgive me for putting it this way, has had a brilliant pandemic. I mean, they've shown how much we depend on a high quality agency that produces data. We're rightly the envy of most of the world. Our data is just fantastic. But as David said, data don't make judgments, people make judgments. We need the data, but we need the judgments. And that again, means science, it means politicians. Scientists are not elected to lead the government, nor should they be. So government has to take decisions. They have to listen to science and they have to listen to the people, the community. So there's some lessons here. If we ignore those lessons, oh my gosh, we've got a grim future waiting for us. But they're pretty fundamental lessons. They relate to prevention. But what's going to be the nature of working life? What's going to be the nature of conditions? I put in my Build Back Fair report, if you look at child well-being among the 38 OECD countries, we rank 27th out of 38. One is the best. That's terrible. The US ranks 36th out of 38. I mean, this is terrible. What kind of future are we going to create for our young people? Are we going to use Yvonne's phrase, are we going to invest not just in prevention, but in creating a better future for our young people? And as I said, we know what to do. I've reviewed the science many times. So yeah, I'd like my next 10-year-on report, or whoever's going to do it, to say we learned some very important lessons and things changed as we came out of the pandemic. We put the societal effort into building back fairer. But so far, the signs aren't brilliant. We've got to do better.
And Yvonne, same question to you. So if Sir Michael is optimistic but not too optimistic, was how I would read that. what are the key things that we can take away from COVID and actively apply so that we are in a better position in a decade's time?
Well, for me, there are a couple of things. One is very interesting, and one is actually good, and it's maybe the stage of life I'm at. But the interesting thing is that as a public health doctor, I thought I knew mostly about how people lived. Did I know? No, none of us knew. What we found is what has been described here, but also, how the whole country operates. And you can't go forward on a health platform without really deeply understanding why people do what they do and how the country works. And it's not a simplistic thing, but when you've got the grip on it, you've got to keep that grip on it and actually use it to advantage. So why did people go to work when they were unwell? Here's one example. Because a lot of people had to go to work. They weren't on benefits, they were going to work because they were in a situation where if they didn't work, they didn't get paid or their business went wallop. And it's not easy to mitigate that. And blaming people for doing what they think is the right thing to do, many of whom didn't ask for money, actually. They didn't ask for the grants. But what it did do was we all suffered as a result of their need, looking at it that way, because the virus transmitted, it hopped around on that dimension. And there are many, many examples of that. So we need to understand and work with people locally much, much better than we've done, much better. The good thing, I think, is that the country has demonstrated that it does care about its older population. It has not had a good experience in terms of deaths, and that is a matter of great sadness to all of us. However, nevertheless, we do actually value our older people. And for our next generation of older people, we want to see those older people do well as well. We want to see them have good, healthy life expectancy, but also make a contribution, which, some of the oldest in our society are now making very visibly. And we're very proud of that and we're benefiting from it. But they cannot do it if their life has been so disadvantaged that they're basically knackered by the time they get to their early 60s. So we have to take that message away as well.
Thank you. And a quick question before I come on to David as well, Yvonne, just to pick up on some of the ones we've had coming through, which is, I put you on the spot slightly, but I'm sure you will have an answer nonetheless. But someone has said, essentially, is government serious? You talked about investment, and clearly that, that is the big thing that you yourself have said has been lacking in some senses for public health for many decades, in fact. Do you think the question is, do you think the Treasury really understand the value in a business case for prevention programs? So are you optimistic that the government, and particularly the Treasury, who obviously hold the purse strings, are going to invest in this agenda?
Well, there's been a massive investment in this pandemic, and without question, the money has flowed. The issue going forward will be, how do we make, while that opportunity is there, how do we make the very best of that, build on it, and demonstrate that it can actually work for people? And that's not about government, and it's not blaming people. It's to say, in the channeling of this resource to those who are most in need, can we demonstrate levelling up? And that is a massive implementation challenge. And we all need to work on that.
Thank you very much. And David, the same question originally that I put to Sir Michael and Yvonne about what's the big thing we can take away from COVID and build on so that in a decade's time we are in a better place. And I guess linked to that, one of the things we haven't talked about very much is patients themselves and what individuals and patients can do in terms of being one of the best advocates of their own health and managing their own health. So question to you, COVID and what we can build on, but also within that, what is the role of patients and individuals? Because we have seen actually individuals very reluctant during COVID to go and seek help when they've needed it, when it's not been related to the pandemic.
Yeah, so from a COVID perspective, I guess it's reflecting back onto the collaborative approach across many areas, and I think doing things differently is definitely been one of the themes of the last 12 to 14 months, and perhaps doing things at a pace that wasn't seen previously. And I think, to Yvonne's point, a lot of that probably stems from an increased level of investment that came through pretty quickly in many areas. I guess it's probably having that flow through to the right areas with the people with the right approaches to make the most of it. So I think it's, if indeed investment will continue to flow at the current levels, it's about how then it's apportioned and invested correctly and appropriately and fairly. I think is some things. And I think, look, I'll call out a couple of examples to sort of also give the government some credit as well. Often, what we have seen, I mean, particularly from an oncology perspective, is with working with NICE and NHS England, they've provided earlier access to medicines, different medicines that were less, I guess, less challenging to manage through COVID, through the initial waves. So they've managed to work much faster than they'd ever done before to review and appraise products and make them available and fund them as well, which has led to then probably the treatment rates being higher than they would have been otherwise. So I think that there is some credit there. There's some learnings there about how the system can work collaboratively, can work faster to really make sure things are set to improve outcomes for patients. That's just on the treatment side there. That's a small part, I think, because I think you're really right that there's how do we try and reach patients that aren't reachable normally? And I think this has been an issue and will continue to be an issue. So I think if we can project forward 10 years, it would be that we found a way to do that. I wish I knew what it was. I think there's a lot of really good ideas about how to do it. I mean, with the campaign that we supported and run, we took a really traditional approach. We more or less ignored social media and digital and other channels, because I think through the work we did with the collaborative group, we realized the patients we were trying to reach just didn't engage with this. So it would have been a wasted effort. So we had a very traditional approach with signs on buses, bus stops, pharmacy bags, really just trying to engage the potential patient or their carers to spot signs and symptoms and to try and present. So I think it's going to take a whole range of different approaches, but definitely there are a lot of learnings there to build upon, and I think it's trying to then prioritize what to tackle first. Even we know a lot, there's been a lot of reports, there's a good set of recommendations in almost everything, but it's ultimately where do we want to tackle first, and what do we want things to look like 10 years from now, and kind of work back from there.
Perfect, thank you. And just going through a few more questions, one specifically for Yvonne. You mentioned, yes, we collectively need to kind of really see value in the health of the nation, but you also mentioned that individuals need to really value their health as well. And so the question is, what can government, communities, healthcare organisations and individuals do to really ensure that at a personal level, we are also focusing on our health?
Well, there are two answers to that. Michael would say, and I would agree with him entirely, that, if you're struggling from day to day, it's very difficult to deal with your health. And we know that from the pandemic, where, we've all struggled in various degrees of difficulty. But those who struggle most will not look after themselves. And just depending on them to do that is not going to get them or us collectively anywhere. So, this differential support to people whose need is great will get them hopefully to a level where they can look after themselves and their health better, because they're not struggling, so much with just day-to-day life and disadvantage. But for those who can, and that is a good proportion of the population, one of the saddest things is to see people who actually are not thinking about their health as an asset. And I just think you have to get into that mindset if you are in a position that you can. But collectively, I think we all need to care about those who are disadvantaged, because it harms us all. And it's not fair. It's just unjust. And therefore, we need to take that sense of outrage with us going forward from this pandemic.
Thank you. And a couple of other questions I'm going to tie together, Sir Michael. So one question is, given the need to focus on the social determinants of health in the very widest sense that you've described, is it a mistake, the question is asking, is it a mistake for the newly announced Office for Health Promotion to be based within the Department for Health and Social Care? Will that mean there is a narrow kind of healthcare focus? And linking that to another question, which is someone talking about how fantastic your description of sort of a life course approach to health is, and needing therefore a whole system approach to it. And I can remember I spent time as an advisor in the Department for Work and Pensions, and honestly, it was so difficult to try and get health and unemployment connected in together. And I think a lot of progress has been made in the last few years, but that's just one example of where the system is kind of doing this rather than kind of working together. So is it a mistake to focus health promotion within the Department for Health and Social Care? Should we have something cross-government? And if yes or no, how do we get that whole system response? Is it just at a local level? Are we going to have to rely on that, like you were describing, is going on at the moment?
So this question of the role of a health department, which usually means a healthcare department, is fundamental, and it's not unique to the UK. The World Health Organization, by original Commission on Social Determinants of Health, was done for the WHO. The World Health Organization is managed by ministers of health. They are the delegates, and that's the management body of the WHO. So I produced commission reports saying this is for the whole of society. And ministers of health said, but we're providing better health care. What's wrong? We're doing everything. So this is a challenge we have globally. Nobody cares more about health than people in the health sector, but their focus is usually for healthcare. It's usually very narrow. And Dr. Tedros, the Director General of WHO, when he asked me to be his advisor, he said, I can tell you, when I was a Minister of Health, I was the least important voice in the cabinet. So the problem with leaving health to the health department is not unique to this country. It's a global problem. And there's the Director General of WHO explaining to me that when he was a Minister of Health, his voice mattered much less than the Minister of Finance or other ministers. So it's a problem. We have the expertise within organized public health, and that tends to be related to the Department of Health and Social Care, but the action needs to be for whole of government. And that's not straightforward. I'm probably the least expert person you could ask on machinery of government questions. I have no idea about the most sleek machinery of government, but then nobody else does because they keep changing it. So it's not as if there's a clear answer to this question. But I'm delighted that we have the expertise. People like Yvonne have this expertise. How you then go from there to get whole of government action and not narrow the agenda too much to within the healthcare system, I'm not sure of the correct answer to that question. It may be why local government has been so good at taking this agenda forward, because it tends to be led by the chair and the chief executive of local government. Public health is very important. The expertise has come from public health, but you've got chief executives of local government and political leaders taking the action. So you get that cross-government action. So it's a major challenge putting health promotion within DHSC. It's a major challenge, and we've got to work, but that's how most countries do it anyway. And we've got to work to make sure that challenge doesn't narrow the agenda too much.
Thank you. If I may then go to Yvonne, who will be the person here, I think, who can talk the most about the challenge of trying to move the different parts of government all towards a certain direction, in this case, prevention. I suppose, how confident are you that, the new office is going to be able to pull in the relevant government departments, local government, that's going to need to deliver, if we're hearing that transport, education, unemployment, kind of skills, these all sit in different places, that healthcare has very few levers over. So, how confident are you? And I suppose it's a very specific question from my part, should this be an objective of every Secretary of State in a government department, rather than just sitting with the Secretary of State for Health and Social Care?
Well, a couple of things. I think my international interviews recently have told me the importance. People invest in relationships internationally, and they do that from national through to the field. What I call the field is to local government. And they actually pay for people to make sure those relationships are sound, and that they are active, not just partnerships, but relationships where people will trade with you, will do things for each other. Now, we don't have to do much trading with local government. They get it, as Michael said. And it's been one of the great joys of the last, 7 years to find out how much they get it, and have really stepped up. We just need to build on that. I think the great silent partner on prevention in the round, although there are great examples, has been the NHS. We now have a white paper which wants the NHS to take its part in this. And I think we haven't spoken enough about that. Holding to account there and bringing the skills into that environment to enable it. They want it, they're just very distracted, but they have a huge heft in this country. Across government, I've seen it work in the pandemic very well indeed. But always with government departments, you need to come from where their need is. So providing, their answers in the environment where they will get the public health dividend of this is the great skill of government, those who work in government. And that does depend on skill and patience, but it can happen.
Perfect, thank you. I have one final question for Dave, but I know, Sir Michael, that you need to rush off to another meeting. Did you want to?
Yeah, I just wanted to say one more positive thing, because what Yvonne said reminded me when she talked about the NHS and partners, starting with the Royal College of Physicians, and then other medical Royal Colleges and the Royal College of Nursing, and then a whole slew of other health-related organizations. More than 140 health-related organizations have signed up to a Health Inequalities Alliance, which is not just about healthcare. It's about how these various health-related medical Royal Colleges, the nurses, British Diabetes, Lung Foundation, and so on, how they can all get active on social determinants to improve health equity. And then would you excuse me if I had to dash off?
Yes, of course. Thank you. It's been brilliant having you, and loads of positive feedback already in the Q&A as well. So thank you so much. I am going to go to a final question very briefly, which actually links beautifully off of Sir Michael's last comment, but for David. So someone has asked, what role can businesses play in helping to tackle health inequalities? And of course, partly what Sir Michael there was saying was about the alliances and the collaboration, and both Yvonne and yourself, David, have mentioned this, but is there more the businesses themselves and MSD can be doing to really drive better outcomes and close those gaps?
Yeah, I think there are absolutely. I think we've seen some of that recently, and of course in the past as well. And I guess before I get to that, I'm quite curious about the integrated care systems as they come through and local government interface, and how that might help solve some of the challenges we've got. But that's probably for a complete other webinar discussion, I would have thought. But I think that there's a lot that industry businesses can do. I think there's a lot of skills we have that we can help upskill members of the NHS or trusts or different areas around where there is a need, and I guess to Yvonne's point of how you best articulate that need to particular other potential partners, or how you negotiate around that. I would have thought sometimes you have to put it in the terms of the person you're speaking to in terms of what they get for it. So I think there's a lot we can do to support there, and equally there's been many different things that have been done over the years and recently as well with the pandemic on supporting different parts of the system. But I think back to one of your earlier questions as well is around what more can we do to support the patient? What more can we do to help them get access to information? I think there's a lot business can do to support this as well, because a better informed patient generally is one that will ask more questions, will be more curious, and will, to use Yvonne's language, invest more in themselves and their healthcare and their healthiness, as it were. So I think there's a lot that can be done there. Just noting time, so I'm gonna stop talking now and hand back to you.
Thank you so much. And yes, I will wrap up now. I'm conscious we're exactly at 1 o'clock. In fact, I've heard the church bell ring, which is opposite where I'm sitting. Can I say a huge thank you to Yvonne and David, and obviously to Sir Michael, who's had to dash off. I think that has been an incredibly rich discussion, and so many aspects that certainly we at Reform will be taking forward and thinking about, and hopefully being able to kind of contribute and help with the debate. Can I also say a big thank you again to MSD, just, for supporting this work. It is what enables us to be able to have these conversations and in these discussions, and hopefully contribute to pushing things forward. I'm going to finish on just reflecting at just how many positives we did identify in this discussion. And it can be that we, I guess, focus on the negatives and the challenge ahead, but actually each one of our panelists has pointed to real progress and a real opportunity coming out of the pandemic to genuinely build back better, to use the government's language. And I think that's a fantastic note to be able to end on, that there's a real opportunity for us to make a significant dent in the health inequalities that we're seeing, and drive the prevention agenda forward. So a final thank you both for joining me. As I say, it has been brilliant, and I know, Yvonne, that you've sacrificed another meeting, an important one for us. So thank you so much, and thank you to everyone who has joined us this morning.